Well, thank you for the kind introduction and for inviting me to one of my favourite countries. I'm very happy to be here in Turkey. The weather is much better than in UK as well. So I'm going to talk about neurodevelopmental disorders, and these are my disclosures. I don't have any income apart from the university. So I just want to highlight where we are, because sometimes people say they know London in the UK, but not Cardiff. So Cardiff is here. It's about 2 hours from London. It's famous for coastline, beautiful beaches, castles. And this here is our building. I don't know how they managed to get the sunshine, but they managed to get one day to get the photograph. So our labs are upstairs and our academic clinics are downstairs. So this afternoon, I'm going to talk about neurodevelopmental disorders. I'm going to first cover what I mean by neurodevelopmental disorders. I'm then going to give some sort of rationale for why they're grouped together. And then I'm going to talk about research, which makes it quite difficult for us as clinicians as to how we conceptualize neurodevelopmental disorders. So just a bit of research to think about how we do our clinical practice. And then I'm going to talk about how research findings might have implications for the patients we're seeing and also the services that you work in. And I understand you're from all over Turkey, so I'm quite interested afterwards to hear about your different types of services. So first of all, what do I mean by neurodevelopmental disorders? So this is the DSM-5 grouping, specific learning disorders like dyslexia, motor coordination, developmental coordination disorder, dyspraxia, as well as tic disorders, language, communication disorders, autism spectrum disorder, ADHD, and intellectual disability. Now, I don't know what it's like in Turkey, but generally in the UK, for medics, we would see out of those autism, ADHD, and maybe intellectual disability with comorbidity would come to us. The rest would not. They would go to some other member of staff. So changes in diagnostic criteria. Although DSM-5 obviously is very influential in the research field, much of the world we use the WHO, ICD-11, but both use the term ADHD. ICD-11, we've now used the same term as the Americans, so hyperkinetic disorder has gone out. I don't know what it's like here in Turkey, but patients never knew what hyperkinetic disorder was anyway, so it makes it easier. It's just ADHD. Autism spectrum disorder. Instead of having pervasive developmental disorders with autism, Asperger's, these have all been put together as ASD. And some people with autism don't like this, particularly Asperger's, but that's what's happened. The really big plus, I think, it happened with DSM-5, 2013. We were doing it anyway in clinic. Any clinician will know ADHD and autism go together so commonly, but we weren't allowed in research to co-diagnose them. That changed in DSM-5 and also ICD-11. And that's a good thing because it means at least the research participant definition is now more like what we see in clinic. I think one controversy, ICD-11, is tic disorders like Tourette's is actually not grouped here, and I think that's a mistake. They've put it with neurological disorders, so we'll see. So the definition in both is that their onset is in the early developmental period, and there are multiple developmental difficulties, and of course, as we know, you have to have interference with functioning, social, academic, etc. I just want to highlight that, and medical students often raise this with me, that the term neurodevelopmental disorders is used really broadly. If you look at some of the papers, it's not like the DSM-5 or ICD-11. Sometimes pediatricians will use it to describe causes, single causes like preterm birth or a genetic syndrome, a single gene disorder. But actually, DSM, ICD-11 are neurodevelopmental and mental disorders aren't based on etiology, they're based on symptom presentation. So, but you do see literature there. Sometimes people call epilepsy or early onset conduct disorder as neurodevelopmental. And some people, I mean, I work in a department where more people work on psychosis than on ADHD and autism. They say, well, that's neurodevelopmental. And of course, there are neurodevelopmental features of many conditions, but for this talk, I'm talking about the DSM-5 ICD-11 grouping. So that's what I mean by neurodevelopmental disorders. So why are they put as an umbrella together by DSM-5 and ICD-11? Now, I don't approve of diagnostic classifications in every aspect. Some things they're very useful for, but I actually think there is a rationale. Apart from starting early in development, they tend to be more steady state rather than episodic. So some of the conditions we see as psychiatrists, like depression or bipolar disorder, these are episodic. People can be well in between. Whereas conditions such as ADHD, autism, intellectual disability, these are more steady state. Prominent cognitive and learning differences for these conditions. And also there are maturational changes. Because there are maturational improvements in development, like motor, writing, reading, social, language, there are maturational improvements with these conditions, which makes it different from psychiatric disorder. But having said that, the majority with neurodevelopmental diagnoses don't just catch up and become normal. For the majority, challenges persist into adulthood. Now, I thought it was quite interesting. This talk is titled Neurodevelopmental Disorders, but I was told the majority of people here would be child and adolescent psychiatrists. But actually, neurodevelopmental disorders is lifespan. It's not. It might start in childhood, but actually the majority persists into adult life. We know that for neurodevelopmental disorders, there is an increased male to female ratio, 3 to 4 to 1, but it's much more accentuated in clinics, especially child psychiatry or pediatric clinics, where 20 years ago it was about 7 to 8 to 1. I think it's not as marked now. Less of a sex bias in adult clinics, but the evidence really is telling us that girls are missed or the diagnosis can be delayed. Perhaps they develop some other disorder and then they get picked up later. So we do have this bias, and I think it's important as clinicians to recognize we have this bias. There's another really good reason for grouping them, and I think this is the strongest reason for thinking about putting neurodevelopmental disorders together, is overlaps are typical. They don't exist. ADHD, autism, language disorders, they might have different specialists seeing them, but overlap is the rule. It's not the exception. And that, at least, certainly when I was trained in medicine, we did get taught to make one diagnosis, and that's quite difficult because actually neurodevelopmental disorders rarely occur in isolation. And actually, it's really important to consider those comorbidities because these children will be the most impaired. They'll be having the biggest difficulties. They're the ones who are going to be referred to your service more quickly. They will also have the worst outcomes. So, I don't know, in your areas, whether you have ADHD clinics, whether you have autism clinics, whether you think you're a consultant with special interest in one of these, but actually you have to know all of them. And that's quite a difficulty because I can see heads nodding that different specialties deal with different types of neurodevelopmental disorders. The other reason for grouping, apart from the phenotype or clinical overlap, is that they share risk factors. And this is, I'll come to why it's clinically important. There's lots of genetic studies showing that people from the same families and the same genetic risks, if you look at twins, it doesn't just lead to ADHD or just to autism, it increases the risk of all the neurodevelopmental disorders. So that genetic liability goes across them all. So that's really important and another rationale for grouping. Now, you don't have to suddenly become geneticists to really know this, but neurodevelopmental disorders, amongst the brain disorders, are probably some of the most strongly genetic, much more than depression or anxiety. We know that there are different types of molecular genetic variants that contribute. So first of all, we've got what's known as rare Apart from the Mendelian disorders, we now know that there are these rare copy number variants, duplications and deletions of small segments of the chromosome. The most famous, if you like, is 22q11, but now recent research in the last 10 years has shown these are enriched in not just in people with intellectual disability, the same ones in autism spectrum disorder, ADHD and Tourette's, and the same location can result in all of these, any one of these. Now again, in the UK, we do screening for intellectual disability, like genetic screening. We don't yet do it for the other conditions, and the evidence doesn't suggest you need to do it unless there's some other clue. For example, the child looks dysmorphic or has some unusual features. But the point I'm making is that these copy number variants don't respect diagnostic boundaries. The other types of studies, but they've only been done for ADHD, autism and intellectual disability, is looking at damaging mutations in coding regions of the genome. And they, again, the ones that they cross, the same mutations can result in any of these. So they're not specific. And common gene variants also go across neurodevelopmental disorders. It's another talk, but common variants can also increase risk of psychiatric disorder. I've got on this slide intellectual disability, ASD, ADHD, Tourette's. If I come to you next year, I might have another slide because we've just found in our lab that these rare copy number variants, not only the same ones go here, they also increase risk of speech and language problems, reading difficulties, and motor coordination difficulties. So that's something interesting because they wouldn't ordinarily come to medical attention. Early environmental risk factors, we don't know lots of them, but preterm birth exposure to toxins, again, the risk is across all the different neurodevelopmental disorders. So there is a rationale for clustering them. Lots of commonalities, early onset, the steady state, the shared risks, and the strong clinical overlaps. So am I saying we don't need the separate diagnoses, autism, ADHD, Tourette's? No, because why do we need both. We need the grouping and we need the separation, because there's also important difference, like stimulant medication may help someone with ADHD, it's not going to help core features of autism. The educational strategies for somebody with a reading difficulty are not the same as somebody with a motor coordination difficulty. So we need grouping and splitting. I just want to say, for those of you, maybe you'll be different here in Turkey, but most clinicians in the UK don't really want to know too much about genetics, but I say, it's very relevant to clinicians. And the reason is, you might think, you're seeing a child with ADHD, or with autism, or intellectual disability, the risks that created that difficulty in the first place are also going to increase the risks of other neurodevelopmental disorders. So always check for comorbidities. The important thing as well is that the parents of the child you're seeing and their siblings are also at elevated risk. You might think have the clue they will also have ADHD, but they might have another neurodevelopmental problem. So certainly in my clinic, it's really common. See a child with ADHD, the brother's got autism, another sibling has got a reading difficulty, and father has got speech and language difficulty. So you see that family. So it is clinically relevant, the genetics. And I think another important way that it's relevant is, if you're a child and adolescent psychiatrist, you might not think so much about the parents' neurodevelopmental health. Have they got a neurodevelopmental disorder? And yet many of your interventions, whether it's a behavioral intervention, whether it's actually, managing the medication, requires good parent communication, literacy. So it's just important for us to realize and consider whether the parent also has a neurodevelopmental condition. And again, I'm guessing it may be similar here in Turkey. We have quite a lot of parents, once a child has been diagnosed, then they go to see the adult psychiatrist because they recognize actually they have had difficulties for years, and then they understand perhaps why. So the practical implications in your services. How are you going to assess? You have to assess across all these different neurodevelopmental disorders, and one person doesn't have those skills. How are you going to bring all these different professionals, different sectors together? It's not always easy, and who does what, and people might call things different things. So that requires quite a lot of work for neurodevelopmental disorders. So in Wales, you might not know this, but in the UK, our health and education, we have a separate government. Scotland has a separate government. Wales, we have a separate government. Our government in Wales is much more socialist, and we, as scientists, have quite a lot of influence over what they do. So in 2016, instead of having separate ADHD and autism clinic, managed to get them to put all the child neurodevelopmental clinics together. And we'd have a speech and language therapist, a psychologist, psychiatrist, pediatrician, and pharmacists all together. I'm not saying it's without problem. We still have a wait list, but we tried to reduce that sort of separation. So that is the rationale for grouping. So the takeaway message, yes, is a good reason for grouping, but we can't get rid of the separate diagnoses either. So this is the bit science to make it more difficult for us as clinicians. First of all, as clinicians, we're taught about diagnoses. And the first bit of research is that neurodevelopmental disorders, unfortunately for us, don't behave as nice, tidy, yes, you have it, no, you don't. I mean, I'm sure that you see this every day in your clinical practice, and certainly as a professor, I get I've got some sort of magic hat. Is this child really got autism or have they not? And I'm going to say what we know from the research. Well, first of all, as doctors, we learn you either have a diagnosis or you don't have it. But actually, you can also look at neurodevelopmental disorders as traits, that everyone's got a bit of it. And it's only at a cut point, we call this affected, and we think this is a diagnosis and we'll offer intervention. And I always tell medical students this isn't peculiar to psychiatry. We have this in medicine. We have it for lipids. We have it for blood pressure. We have a cut point. And we say, right, at this point, you will get treatment. It's also worth noting that context is important. So the treatment threshold for blood pressure is different today in the UK than when I graduated in medicine. It's become lower that people will treat. The threshold for treating lipids is different in the UK. It's much lower in the United States. So it's a bit arbitrary. So it's not just us in psychiatry. This is physician general medicine. We know that if we look at neurodevelopmental disorders as traits, they also are very closely related. They're very strongly correlated. We also know that the risk factors, whether you look at conditions like ADHD and autism as a diagnosis, yes, no, or as a trait, it's the same risk factors. So they're clearly related. So I'll give you an example. This is the genetic risk factor. For the genetics, I won't go into the genetics, but the genetic risk for ADHD diagnosis shows a genetic correlation 0.9. The maximum you can have is 1 with the ADHD trait. So basically the risks, whether it's preterm birth, genetics, there's the same ones apply for higher scores on the trait as the diagnosis. And also longitudinal and epidemiological studies suggest there isn't just one point and suddenly bad outcomes happen. So somebody who falls just below the threshold will only show a little bit different to one who just falls above. And again, that's true for blood pressure, which is why it becomes a bit arbitrary as to where we have our cut point, and becomes very difficult for us as clinicians, for people with subthreshold autism and ADHD. So, first of all, I just want to make it clear, I'm not saying let's get rid of diagnosis, because our clinical practice is all categorical. Every day we have to make yes, no diagnosis. Yeah? Do you accept this child in your service? Yes, no. Do you start medication? Yes, no. Do you refer into this psychotherapy intervention? Yes, no. It's all yes, no decisions. So we need the diagnosis. But as clinicians, we have to know that the research is showing there's this trait underneath, which means there's no scientific grounds if you're extremely rigid and spend weeks and weeks and weeks getting the correct diagnosis, which a lot of lay people think you can get the correct diagnosis. And I certainly have a colleague, and she sees the child over weeks, she counts up all the symptoms in DSM, and if the child doesn't meet it, they're just sent away without anything. When actually the child who just doesn't meet it should just get a little bit less than the one who meets it. It isn't just like quite so straightforward, but of course for clinicians it's very difficult to manage. The colleague who's a little bit rigid and, she's got a really long waiting list, but it's not a good method to, maybe it'd be better to say we'll see the poorest children first. I don't know. But we have to consider the impact of sub-threshold traits. We have to know as clinicians that is what the research is showing us. The second challenge, we learn about diagnosis, but actually you will all know this as clinicians. You have an ADHD clinic, autism clinic, nobody is the same. This is really important because when you look at the research, you don't get any sense of that. So the evidence-based medicine you're practicing is actually really difficult because no two people are the same. So the people in the research paper might be very different to your clinic because they could be very different in terms of the number of core diagnosis symptoms, like the number of inattention or the number of hyperactivity. The types of symptoms might be different. So one child might have extreme impulsiveness, another hardly at all, mainly inattention. So the symptoms could be very different and really very different in functioning. So we have a few people with ADHD and autism in our research group. They've got PhDs. And other people in my clinic have got intellectual disability and cannot be in school. We've got a huge difference in functioning. Other people have got hardly any language abilities. Other people are really articulate. So I just want to highlight this issue of bridging science and clinical practice. I was very happy to see that in the title of your conference. So we have the neurodevelopmental disorders, and I've already said they will vary in how much they overlap with the other neurodevelopmental disorders. So you may have a child who's got ADHD, they've also got lots of autistic traits, they've also got reading problems, they've also got tics. So they also will show variation in their cognitive abilities, their overall cognitive ability, but their executive functioning, and that will of course change with time. Also, every child you see will differ in their emotional comorbidities, how irritable or labile they are as they get older, the anxiety, depression, and also the behavioral symptoms. So just want to highlight that makes it very difficult. Number one, your clinics, every single child will be different. And number two, when you're looking at a research paper, it gives you no flavor of actually how different it could be, the sample from your clinic. The other thing that we all as clinicians take into account but won't come out in research papers is a child's strength. A child maybe who's very conscientious, very good cognitive abilities, maybe doing well in school, doesn't get picked up till very late, and the teachers are saying, no, I don't think so, he's very well behaved, doesn't, doing not too badly, doing much worse than anyone else in the family, but not causing problems in the class as a whole. Also, the other thing that could be, and we find this particularly, I was running for many years, a 15 to 25-year-old clinic. If there's a lot, the problems only started appearing later because the parents were providing so much support, doing the homework with the child every day, lots and lots of support, and things only became difficult when the child grew up and started work. Also, a huge difference, some children will be very supported by their environment, others will be in very risky environments. The parent might have a mental disorder, they may start misusing substances, the family's attitudes might be very negative, others will be very accepting. The social context, I would imagine it not as problematic as in the UK, but the social context can be hugely variable. But of course, you've also got a different context here in Turkey. You've had huge changes with refugee influx. So the context is important and will show a variety. So this is a picture done of 6 children with ADHD. She mapped their strengths and weaknesses, and basically it shows what she calls spiky profiles. No one is the same, and you don't get that picture from research. The other important thing is neurodevelopmental disorders show important links with mental health disorders. So I just kind of want to highlight, I've explained that neurodevelopmental disorders are very linked with each other, and I felt very proud that we had neurodevelopmental clinics in Wales. But of course, the minute you start feeling proud, something goes wrong. And something goes wrong is that those children then who develop mental health problems had to access a different service for their mental health problems. So now we're trying to struggle with how do you deal with the mental health problems. So I think we all know that there's really good research. People with ADHD, a lot of them will go on having adult ADHD. Autism, the same. Even people with reading difficulties in middle life still showed spelling problems. But the other factor is that these children you're seeing in clinic also, in adolescents, I saw one last week, can a high risk of developing depression, anxiety. If you're only assessing their ADHD, you might think they've deteriorated and think I've got to up their ADHD medication, and it's actually they've developed something else. Conduct disorder, self-harm, more rarely, but in our research study of ADHD in child and adolescent psychiatry clinics, we did still pick up 10 people with bipolar disorder, not been picked up, had to ring up the clinician, can you just go and reassess this child? Because they're meeting criteria on the research interview for bipolar disorder, they're at high risk of bipolar disorder and psychosis. For those of you who are child psychiatrists, our issue is we see someone with child neurodevelopmental disorders, we follow them up through adolescence, maybe longer. Are we aware, are we monitoring for that? For those of you who are adult psychiatrists, if you're seeing someone with any of these, and it looks it's early onset, or maybe it's not responding very well for treatment. Have you thought about neurodevelopmental disorder? Are you missing ADHD? Are you missing autism? Just to think about it. At the moment in our inpatient unit, we've got 2 children with schizophrenia and ADHD. So, I mean, they've got picked up, but I'm just saying, though, sometimes they can be missed because we tend to think of one thing. The other challenge, DSM-5, ICD-11, the definition of a neurodevelopmental disorder is it's got to onset early. And for those who like looking at the diagnostic criteria, who know ADHD has to have onset by age 12. For those of you who've seen older people, it's very difficult to get them to remember. And of course, if they have school reports, it's easier. But a real challenge in research, I just want you to think, is that there's lots in the world, there are many cohort studies, people who have been looked at from birth and followed up into adult life repeatedly. These longitudinal cohort studies, there's more than 4 of them now, have observed people in adult life who meet all the criteria for ADHD, but when they look back at their records, because they were participating in the study as children, they didn't have ADHD before 12. When it first came out, the paper in American Journal of Psychiatry, it was Temi Moffitt, nobody believed it. They thought it was just one cohort. There's something funny. It wasn't explained by comorbidity, nothing. But 4 more studies have found the same. And we looked at this. We also found late onset. It does look like it's got some of the genetic loading of ADHD, but the proof of it's uncertain if this really is ADHD, in which case it's not early onset. Of course, it could be something like eczema, where you have early onset, then later onset. But maybe this isn't ADHD at all. The crucial thing is whether they respond to treatment in the same way. I mean, for us as clinicians, I'm just telling you that this research is there. It may mean in the future we have to look at our views on age of onset, but just something to think about. This is a paper we looked at autistic traits in the population, because so far all those studies were of ADHD. We found this is in the UK Alsbach cohort from birth. They're now at 30, but we looked at them at age 25. This is their autistic traits. The majority of people went down. There was a small group, it didn't get picked up, who just stayed with high autistic traits, but there was this group that emerged late. So, I mean, that needs replication. but it does then challenge our concept that they will always onset early. And I guess the takeaway message, if you're a clinician, is if everyone meets the criteria and you're not certain about age at onset, is the research is a little bit uncertain here. The fifth challenge, and I just don't know whether it's an issue in Turkey, it's a big issue in the UK. Neurodiversity. Do you have a neurodiversity movement here in Turkey yet? Do you do? So this neurodiversity is challenging the concept of medical diagnosis, and it's really coming through social media. So I'm just going to give you a history because it is really sort of, certainly in terms of social media, a very big influence. So in the 20th century, people used to think autism was due to how mothers reared their children. ADHD, people used to think was naughty children. The role of the mother was highlighted. Actually, the treatment used to be psychoanalytic psychotherapy. Then in the 20th century, there was much more focus on diagnosis in research, not just clinical observations and case series, and much more genetics and neuroscience challenging prevailing psychodynamic understanding of ADHD, autism. So these are some of the papers. You can see huge swathe. So let me turn to what this movement is. So the social constructionist theory opposes the medical model, which the medical model says there's something which is not right with the brain, and we as doctors or psychologists, we need to cure them, mend the person. What social constructionism, it's not within the individual, it's outside. And actually all the disability is because of society's barriers, people's negative attitudes and exclusions. Neurodiversity actually is not totally anti-medical. It was coined by a sociologist in Australia called Judy Singer. It's a very thin book, this. I don't like reading lots in the evening when it's medical books, but this is really quick and easy to read. And she is an interesting lady. She's a sociologist. Her daughter was diagnosed as having autism. She then recognized she had autistic features, and she had a very problematic childhood with her mother, and recognized her mother probably had quite severe autism. So she coined the term neurodiversity, which she basically said was neurological diversity. People are different in their brains, rather than there's something being wrong with their brains. They're just different. But she didn't totally want to dismiss the medical, and she very clearly said she was focusing on higher functioning autism, the type of person who will be getting a university PhD and doing well, higher functioning autism. And she said what she emphasized was social justice and civil rights. And that has actually become a very big movement in the UK, and including in Wales, the civil rights and justice for people with ADHD, autism who are neurodivergent. How can we make the environment suited to their differences? In the same way that, you know, in the UK, you have to have ramps for people with wheelchairs. In work, how can you make it more, in schools, can you make it more inclusive? My own perspective is here in this Lancet Psychiatry article, where I say, for some purposes, neurodiversity is useful, but I don't think we can just get rid of diagnoses. You need both for different purposes. In a school, the neurodiversity might be helpful, thinking about how you accommodate. For us in clinic, we need the diagnosis still. So what could be the potential benefits in your workplace? I mean, some of you might work in universities, you might, so some of the benefits are, right, somebody with autism, the teacher, society saying they have a disease, you, the child psychiatrist, you must cure them. They can't do anything, so they feel really hopeless, helpless. Maybe if they just fall below those symptom thresholds, they're not going to get any help. Whereas if people say, well, these are brain differences, yes, the doctor might see, but you actually have to change the environment so they can function better. And then they have some sort of agency, and it also creates different expectations not just for us as clinicians, because, we can't do everything, but also creates expectations that the family to adapt, the schools, the workplaces to adapt, and how society. So, as I said, I think it can be useful for some purposes, neurodiversity, but I think we still need the yes-no diagnosis. As I've said, as clinicians, we need those boundaries for our decisions and for practicing evidence-based medicine, especially for medication. We need to have some sort of threshold. We can't get rid of diagnosis even if you got rid of doctors, because family society wants diagnosis. People want to understand, why is my child different? If you just tell them, oh, it's neurodiversity, well, why is he different from his brother? So you still need the diagnosis, even if they prefer the term in society neurodivergence. How are they going to get accesses to services and support? Also, there's a sense of group membership and communication, like, I'm sorry, I don't have the Turkish organisations. In the UK, National Autistic Society's big organisation for autism, ADHD Foundation for ADHD. You must have similar ones in Turkey for different things. And people, then they can meet with others in their neighbourhood with, mothers maybe with children with similar things. So you still need those labels. But I'm just raising, it's not always straightforward. So the clinical and service implications of this research. As clinicians, and if you're doing research, you might think, I'm doing an ADHD clinic, I'm doing ADHD research, I only see autism. You can't, you're not. You have to consider the overlap. You're seeing all of them, you're researching all of them. How are you going to deal with that? You also have to think about the overlaps with psychiatric disorder. Are you conscious of it when you're seeing children with a neurodevelopmental disorder? And if you're an adult psychiatrist or a child psychiatrist who's seeing a mental disorder, are you thinking about a neurodevelopmental disorder? And a really wonderful thing, in my view, about being a child and adolescent psychiatrist is we get trained in development, but of course development means everything will be changing. Your assessment that you did of your child with ADHD or autism at age 6 will no longer be relevant at age 10, will no longer be relevant at age 15, and new things will keep happening, the environment will keep changing, the brain will keep maturing, so that is something we have to think. And we have to think of every individual's strengths and risks. That is why I don't think doctors can be quite yet replaced by AI. So, subthreshold traits, this is a real challenge. What do we do about people who fall just below the diagnosis? You're going to send them away saying, no one's going to give you anything. Of course, you don't want to start medicating them, giving unnecessary labels, but they, to give nothing for some people may be unethical. We have to balance making a really completely accurate diagnosis, the expense, time, and the concerns, versus actually helping the family. Of course, you still need a diagnosis, otherwise, you don't want to start giving antidepressants for autism. But you still, there's a balance, because it's a spurious accuracy, is what I'm saying. You need to provide the interventions. Because our diagnoses are concepts. They're supported by tradition and some research, but they're not set in stone. They're not like a diagnosis of a glioblastoma, which has got a definitive pathology. But we still need them to help, but we just need to bear in mind their concepts to help us and families. Same for neurodiversity. It's become very popular and common, but it's a concept, and we have to use it when and as needed. And it depends always on the person and the person. Thank you. I hope I've sped Teshikor properly. Thank you.